Good afternoon to all. Today, as a continuation of our discussion regarding the pathology of male reproductive system, we are going to discuss about the various testicular tumors. So, today's learning objectives are to understand the classification of testicular tumors, to know various types of germ cell tumors, both seminomatous and non-seminomatous germ cell tumors, to know about sex-cord stromal tumors. So when we see the basic classification of testicular tumors are broadly divided into germ cell tumors and sex-cord stromal tumors. In germ cell tumors, we basically see two main categories: seminomatous, which are the most common type, and non-seminomatous. In seminomatous tumors, we see classical seminoma, spermatocytic seminoma, and anaplastic seminoma. In non-seminomatous tumors, we see embryonal carcinoma, choriocarcinoma, and teratoma. When we come to sex-cord stromal tumors, they are Leydig cell tumors, Sertoli cell tumors, and granulosa cell tumors. Apart from this, there are some tumors placed as mixed tumors where there are combination of these tumors. And apart from these all, there are other tumors like the lymphomas of testis, which are placed in the others category. So when we go to the discussion of etiology and pathogenesis of testicular tumors, it is worth mentioning the basic differences between the major two categories of testicular tumors, that are the germ cell tumors and stromal or sex-cord tumors. The germ cells, as you know, present in the testis give the origin to germ cell tumors. The sex-cord tumors derived from the stromal tissue. The germ cell tumors constitute 90% of the testicular tumors. Sex-cord tumors are very rare tumors. The germ cell tumors are highly aggressive tumors when compared to sex-cord tumors. And germ cell tumors rarely produce hormones. Sex-cord stromal tumors, that is consisting of Leydig or Sertoli, as you know, produces hormones. Coming to the epidemiology of testicular tumors, testicular cancer represents about 1% of all the male neoplasms, and it is bilateral in 1 to 2% of cases, and 90 to 95% of testicular tumors are germ cell tumors. So the peak incidence of testicular tumors is from 2 to 4 years is one peak, 20 to 40 years is another peak, and above 50 years is the third peak. When we see geographic distribution of testicular tumors, it is usually common in the Nordic countries, or what we call it as Scandinavian countries, that is Denmark, Norway, Switzerland, and it is less common in Asia. And when we see the race, it is usually common in white men when compared to African Americans. When we see the etiology of testicular tumors, we can broadly see under genetic causes, developmental causes, racial factors, environmental causes, and pre-malignant conditions. Coming to genetic factors, isochrome P arm of 12th chromosome has been identified and is mentioned in many literatures. This occurs due to duplication of the P arm of 12th chromosome. Then when we see the risk, it is 10 times higher in first degree relatives of testicular carcinoma. And when we see chromosomal syndromes associated with testicular tumors, it is Klinefelter's syndrome. Developmental, as we already know, undescended testis is predisposes a person to development of testicular tumor in future. Racial factors, when we see, whites are having higher incidence. When we come to environmental factors, exposure to pesticides and use of exogenous estrogens can cause testicular tumors. When we come to the pre-malignant condition, we have to be acquainted with a term called as ITGCN, that is intratubular germ cell neoplasm. So when we randomly see testicular biopsies, some biopsies may show a tiny focus of atypical cells confined within a basement membrane of the tubules. These cells are usually placental alkaline phosphatase positive or CD117 positive. So this focus we usually called as intratubular germ cell neoplasm, and this is a pre-malignant condition to testicular tumors. So when we come to the pathogenesis of testicular tumors, if you remember in the first part, I have discussed about the normal development of the germ cell. That is, germ cell starts its journey as a spermatogonia, then it turns up into spermatocyte, then it will be transformed into spermatids, and finally it takes the shape of spermatozoa. So this is the normal series of development of the germ cells. But if there is a delay in this development due to impaired functioning of serotonin or Leydig cell function, or due to various environmental or genetic alterations, this gonocyte delay will lead to transformation of delayed gonocyte to pre-germ cell neoplasm in situ. This, if it is subjected to further genomic aberrations, then this germ cell neoplasm in situ has a capability of developing into seminoma, or if there is further genetic reprogramming, it has the ability to develop into non-seminomatous tumors like embryonal carcinoma, etc. Coming to the clinical features of testicular tumors, there is gradual gonadal enlargement and dragging sensation in the testis. The metastatic involvement of testicular tumors usually cause pain, lymphadenopathy, hemoptysis and urinary obstruction. Testicular tumors spread by both the routes, that is lymphatic as well as hematogenous routes. The lymphatics those are involved are para-aortic and mediasternal and supraclavicular lymph nodes. Through hematogenous spread, they spread to lungs, liver, brain and bones. Coming to the most common germ cell tumor of testis, seminomatous tumor of testis, that is seminoma of testis, is described as 4 histological subtypes, that is classical seminoma, which constitutes 85%, spermatocytic seminoma, which constitutes 3 to 5%, anaplastic seminoma, which constitutes 1 to 5%, and combination of the seminoma pattern with other tumors. When we come to the most common germ cell tumor of testis, that is classical seminoma or typical seminoma, it is most commonly present in third decade of life. Usually it is very rare in infants. When we see grossly, the testis become bulkier, that is testis increases by 10 times, and on cut section it is homogeneous grey white lobulated. Usually hemorrhages and necrotic areas are rare. When seminoma is large, it completely replaces the testis with a remnant of normal tissue present towards one side. When we see the microscopy of testicular tumors, it consists of tumor cells which are large, round to polyhedral, has a distinct cell membrane. The cytoplasm contains variable amount of glycogen, which is PS positive, and these tumor cells are arranged in the form of cords, sheets or lobules. There is also stromal component in seminoma, which is infiltrated by lymphocytes. The infiltration of stroma by the lymphocytes indicate immunological response of host to the tumor. Microscopically, we can sometimes appreciate two other variants of classical seminoma, that is seminoma with syncytial trophoblast like gene cells, and anaplastic seminoma when the mitotic activity and nuclear pleomorphism is high. So in this slide you are able to see the picture of seminoma. Picture A indicates the gross appearance of seminoma, that is grey white lobular cut surface devoid of any areas of hemorrhage or necrosis. The B picture shows the microscopy of seminoma. So you are able to see the stroma that is dividing the tumor proper. The stroma is infiltrated by the lymphocytes. The tumor proper is arranged in the form of sheaths, islands and nests, and those consisting of the seminomatous cells. So when we see the immunohistochemical reactivity of these seminomatous cells, they are placental alkaline phosphatase positive, c-KIT that is CD117 positive, and they are OCT4 positive. Coming to other rare variant of seminoma, that is Permatocytic Seminoma, usually represents about 2% of all the germ cell tumors and occurs in an elderly age, that is above 50, and very rarely metastasis, that is usually it is benign. When we see the gross, it is multinodular, having edematous appearance. In comparison to classical seminoma, this consists of cystic change and also hemorrhagic areas. So in this pictograph, you are able to appreciate grossly fleshy, gelatinous and hemorrhagic nodules, and also the cystic change in spermatocytic seminoma. When we observe the microscopic picture of spermatocytic seminoma, it is characterized by polymorphous population of cells. There are small cells and multinucleate gene cells. These cells are arranged in the form of sheaths at area show microsis. There are numerous mitotic figures and there is absence of lymphoid infiltration. When we compare with classical seminoma, there is lymphoid infiltration in the stromal tissue. But here in spermatocytic seminoma, it is absent. When we observe the immunoreactivity of these cells, here they are placental alkaline phosphatase negative. There in classical seminoma, they are positive. After completion of the most common germ cell tumor of testis, that is seminoma, and its variants anaplastic seminoma, seminoma with syncytiotrophoblastic giant cells, then elderly seminoma, that is spermatocytic seminoma. Now we will deal with other non-seminomatous germ cell tumors. Those are embryonal carcinoma. So embryonal carcinoma is common at 20 to 30 years of age. It is more aggressive than the seminomas. 90% of cases are associated with elevation of alpha fetoprotein and HCG levels. It is second most common germ cell tumor, comprising about 20% of all the cases. Grossly, when you observe, there are grey white tumor, fleshy tumor with areas of necrosis and hemorrhage. In microscopy, embryonal carcinoma consists of highly atypical cells with scant amount of cytoplasm. There are numerous mitotic figures, and these cells are arranged either in solid pattern or glandular pattern or microcystic pattern. So highly atypical cells with numerous mitosis. Coming to immunoreactivity of embryonal carcinoma cells, the marked feature is they are CD30 positive, which makes this embryonal carcinoma an unique. So CD30 positivity will differentiate it from seminoma. Apart from CD30 positivity, there are also OCT4 positive, placental alkaline phosphatase positive, cytokeratin positive. Coming to the most common germ cell tumor in children, that is Yoxar tumor. Usually it is diagnosed early part of the life, that is within 24 months of childbirth. In adults, it's usually rare in pure form. It occurs as a part of mixed germ cell tumors. Both in adults and children, the presentation is in the form of testicular mass. So grossly, when we see Yoxar tumors in pediatric age are solid yellow myxoid nodules. In adults, they show hemorrhagic and cystic change. So coming to the microscopy, Yoxar tumor shows medium-sized flattened two cuboidal cells arranged in the form of solid cords or papillary structures intermingled with sinuses resembling the Schwiller dual bodies. Those sinuses with central capillary surrounded with the cells resembling as the renal glomeruli. Also there are hyaline-like globules which are positive for alpha fetoprotein and alpha 1 antitrypsin under immunocytochemical staining. So in this pictograph, you are able to see medium two cuboidal cells arranged in the form of papillary structures or cords, with in between there are fuller dual bodies, that is glomerular-like structures, primitive glomerular-like structures. And towards the extreme right, the photograph is showing small globular hyaline bodies which are alpha fetoprotein positive. In this picture, you are able to see the patchy positivity of alpha fetoprotein, that is interspersed between the cells, is what the classical feature of Yoxar tumor. Coming to highly malignant tumor of testis is choriocarcinoma. Pure choriocarcinoma is very rare. It constitutes less than 1% of the germ cells. As I utter the name choriocarcinoma wherever, either in ovary or in testis, the classical picture that we come across is presence of syncytiotrophoblasts and cytotrophoblast. The primary tumor is usually small and the patient may initially manifest with symptoms of metastasis. So always choriocarcinoma is associated with high levels of HCG. So coming to the gross appearance of choriocarcinoma, these are the tumors which are usually less than 5 centimeters, soft tumors. Hemorrhagic and necrosis areas are very common. And when we see the microscopy, whenever and wherever we utter the term choriocarcinoma, we have to describe as syncytiotrophoblastic cells and cytotrophoblastic cells. Syncytiotrophoblastic cells are large, irregular cells with bizarre nuclei with abundant eosinophilic cytoplasm, which is HCG positive. Cytotrophoblastic cells are regular polygonal cells with clear or eosinophilic cytoplasm with hyperchromatic nuclei. They grow in cords or masses and have a uniform nucleus. So coming to the microscopy, in this picture you are able to see an arrowhead above that is pointing towards cytotrophoblastic cells, regular cells, round to polyhedral cells with scant to little amount of eosinophilic cytoplasm, and the arrow below is pointing towards the large abundantly eosinophilic with bizarre nucleus syncytiotrophoblastic cells with adjacent large amounts of hemorrhage. Coming to another set of testicular tumors, those are the teratomas. The term teratoma, by which we mean that they arise from all the three germ cell layers, that is endoderm, mesoderm and ectoderm. Testicular teratomas are more common in infants and children and constitute about the 40% of testicular tumors in infants, and they comprise about 5% of the germ cell tumors. So they are common in the childhood. Teratomas found in combination with other germ cells tumors like embryonal carcinoma forms 45% of mixed germ cell tumors. About half of the teratomas have elevated HCG and alpha fetoprotein levels. When we see grossly, teratoma present as enlarging mass of testis. On cut section, they are grey white, solid to cystic, at areas honeycomb appearance. And when we observe the gross picture in this slide, we are able to see yellow areas constituting the adipose tissue and the white areas, focal white areas, representing the cartilaginous areas. So histologically, when we observe teratomas, we usually categorize them as mature teratomas, immature teratomas, and teratomas with malignant transformation. Coming to mature teratomas, it consists of derivatives of all the three layers, that is either cartilage, smooth muscle from the mesoderm, or various epithelial like squamous epithelium or respiratory epithelium or intestinal epithelium or neuroepithelium from ecto and endoderms, but all are in full mature form. So when we see the components fully mature derived from three different germ cell layers, we call it as mature teratoma, has a favorable prognosis. So when we see in a teratoma derivatives of all three germ cell layers, but in primitive form or poorly formed form, then we categorize it as immature teratoma. And the frequent finding in immature teratoma is there are certain mitosis. In a teratoma, whenever we observe the malignancies which occur in organs, fully developed malignancies like squamous cell carcinoma, adenocarcinoma, or rhabdomyosarcoma in a teratoma, we call that teratoma as teratoma with malignant transformation, and it is highly rare form of teratoma. So this is the pictograph of teratoma, a mature teratoma. Towards the left side, we have neuronal tissue, developed neuronal tissue. Towards my right side, we have a fully developed gland lined by columnar epithelium. In between, a fully developed smooth muscle separating these both tissues. So when we come to the second category, that is after germ cell tumors, the next category of tumors are the non-germ cell tumors or sex cord stromal tumors. So in sex cord stromal tumors, the two important entities that we are going to discuss are Leydig cell tumors and Sertoli cell tumors. Coming to Leydig cell tumor, Leydig cell tumors comprises 3 to 5% of testicular neoplasms. They occur both in adults and children. Children present with endocrinological symptoms and adult presents as testicular mass and have gynecomastia. Grossly, when we see Leydig cell tumor, due to presence of Leydig cell, the tumor has obtained the color of gold brown. When we see the microscopy, the tumor has a uniform round cells with round nuclei and well developed eosinophilic cytoplasm. There are cytoplasmic inclusions or Ranke crystals in Leydig cell tumors. Coming to another rarest form of non-germ cell tumor or sex-cord stromal tumor, serotonin cell tumor, which accounts to less than 1% of testicular tumors. It also occurs both in children and adults, usually presents as testicular mass, and males present as with gynecomastia and impotency. Tumor is well circumscribed with pale yellow in color. When we observe the microscopy, usually tumor consists of neoplastic cells arranged in the form of tubules surrounded by the basement membrane, and those cells have clear cytoplasm. Finally, when we have completed the discussion of the germ cell tumors and non-germ cell tumors, in classification of testicular tumors, there are certain tumors placed in the category of others. So one of the important entity among the tumors placed in others is testicular lymphoma. So the testicular lymphoma is one of the type of non-Hodgkin's lymphoma. Usually they occur in persons above 60 years. They usually are the common mimickers of testicular tumors. So the type of non-Hodgkin's lymphoma which are common in testis are DLBCL, that is diffuse large B-cell lymphoma, followed by Burkitt's lymphoma and EBV positive extranodal lymphoma. These testicular lymphomas have high propensity for central nervous system involvement when they metastatize. So with this we complete the discussion of testicular tumors. The take home message of this discussion is testicular tumors are broadly classified into germ cell tumors and non-germ cell tumors. Non-germ cell tumors are sex-cord stromal tumors. In germ cell tumors, again we subclassify them as seminomatous tumors and non-seminomatous tumors. In seminomatous tumors, classical seminoma constitutes the majority of testicular tumors with peak incidence in third decade. In non-seminomatous tumors, the second commonest tumor is embryonal carcinoma. The commonest non-seminomatous germ cell tumor in children is Yoxar tumor. Highly aggressive non-seminomatous germ cell tumor which rarely occurs in pure form is choriocarcinoma. In non-germ cell tumor, serotonin cells and Leydig cell tumors, they present with hormonal imbalance, especially male present as impotent and has gynecomastia as presenting features.